The 1-hour bundle, measure the lactates, remeasure if more than 2 millimoles per liter to guide the resuscitation, and blood culture must be sent and it must be obtained before the antimicrobials. Broad spectrum antibiotics administer immediately, and fluid resuscitation 30 ml per kg balanced crystalloid if MAP is less than 65 or lactate is more than 4, and vasopressors start if hypotension during or after the fluids to maintain a MAP target. We should not wait until central line is secured. We can even start in the peripheral line is the newest recommendation. And optimization, this prolonged infusions for the maintenance of the beta lactams after the initial loading dose, and the MAP targets as we have discussed earlier. And the respiratory, this awake proning is suggested for the non-intubated patients also. And low tidal volume ventilation, as we know, for the ARDS 6 ml per kg, and preferably we have to use high flow nasal cannula over the NI, non-invasive positive pressure ventilations for acute hypoxemic failure. And this is the de-implementation list. The key don'ts: do not use QSOFA as stand-alone screening tool. Do not use high-dose vitamin D for sepsis treatment. It causes sepsis cohorts. And do not use IV vitamin C for sepsis treatment. It lacks clinical benefit in robust trials. And do not use hydroxyethyl starches or gelatins for resuscitation. And do not use routine IVIG for sepsis or septic shock. And albumin also is considered for the specific set of patients, and it is not recommended for everyone. And there is a stepwise vasopressor escalation: norepinephrine, vasopressin, and epinephrine. Add dopamine if there is cardiac dysfunction is also present. And this one which highlights the use of initial antibiotic timings. If sepsis is definitive or probable and shock is present, immediately administer antibiotics within the first hour. And if the shock is absent, we can immediately administer antibiotics and then see for the causes. And then sepsis, if it is possible and shock is present, immediately start antibiotics. If sepsis is possible and shock is absent, then we have to do rapid evaluation, infection versus non-infectious things, and urgent evaluation. If suspicion persists for more than 3 hours, then we have to administer antibiotics. And advanced support we have discussed. And these are the sepsis guidelines 2021 versus 2026. These are the key changes, and the bottom line is to treat smart and systemic optimization, and also focus on the long term outcomes.